Bismillah ar-Rahman ar-Rahim. Thank you very much for the organizing committee for the invitation. I'm really happy to be here. So today I'm going to speak about splenic B-cell lymphomas and leukemias. This is the outline of my talk. And I will start with just highlighting that in this talk I'm going to talk about only B-cell lymphomas. So we will not cover T-cell lymphomas. And also splenic B-cell lymphomas can be divided into two subgroups. Lymphoma that arise or the primary disease started from the spleen and go out. Or the second group is, as you know, lymphoma elsewhere and invading the spleen during the progress of the disease. So today we will talk about the primary splenic B-cell lymphomas, and the term splenic B-cell lymphoma covers this group of cases that started from the spleen. Okay, so the current classification, as you know, the WHO fourth edition subclassify the splenic B-cell lymphomas and leukemias into four subgroups: the splenic marginal zone lymphoma, the hairy cell leukemia, and then splenic B-cell lymphoma, leukemia unclassifiable, that includes two subcategories: the splenic diffuse red bulb small B-cell lymphoma and the hairy cell leukemia variant. As everybody knows, the classification is a hot topic these days. So the fifth edition of the WHO classification did some minor changes. So they subclassify splenic B-cell lymphomas into, I would say, 5 subgroups. The same one, the splenic marginal zone lymphoma, and the second one, hairy cell leukemia. And they put as a specific entity or a subtype splenic diffuse red bulb small B-cell lymphoma as a category, and then splenic B-cell lymphoma leukemia with prominent nucleoli that includes hairy cell leukemia variant and B-cell pro-lymphocytic leukemia cases. The ICC's classification subtypes the splenic B-cell lymphoma exactly similar to the fourth edition of the WHO. As you know, the authors of the fourth edition WHO are the same one who did the ICC classification, so they follow the same subclassifying system. So I will start with splenic marginal zone lymphoma. So it's a B-cell neoplasm comprising small lymphocytes that surround and replace the splenic white bulb germinal centers, efface the follicle mantle, and merge with a peripheral marginal zone of large cells. It accounts for about 2% of all lymphomas, and patients usually presented with a median age of 65 years old, ranging from 30 to 90 years old. Men affected more than women, and typically patients presented with fever, weight loss, night sweats in 50% of the cases. Splenomegaly is seen in more than 70% of the cases, mostly presented with anemia, thrombocytopenia, or leukocytosis. Autoimmune hemolytic anemia and infections in 10%, and there is some association with hepatitis Z virus, especially in southern of Europe. Splenic marginal zone lymphoma, from the name, tend or prefer to start from the spleen and invade the marrow, the peripheral blood, to a lesser extent the liver, and rarely involve peripheral lymph nodes. How does it look? So in the spleen, it has a very characteristic morphology features. It has a micronodular pattern and what is called the biphasic cytology, where the marginal zone is expanded and composed of medium-sized, widely spaced cells, and inner zone or the darker zone, and it has or show mostly follicular replacement, and the red bulb sometimes, or mostly it is partially involved. In the peripheral blood, mostly splenic marginal zone lymphoma are small lymphocytes and mixed with villous cells. If you are lucky, you can see the typical bipolar or polar villous lymphocytes. Sometimes it is only from one side. In the marrow, it shows a characteristic intrasinusoidal involvement mixed with intratrabecular and interstitial pattern. And we can see here a low power of a bone marrow showing like numerous of small nodules mixed with some interstitial pattern, and the higher power with CD20 highlights the characteristic intrasinusoidal pattern where the lymphoma cells follow the exact shape and size of the sinuses and like show some sort of a single line pattern. The immunophenotypic features of splenic marginal zone lymphoma, it is a it's a B-cell lymphoma and show the pan B-cell markers like CD20, BCL2, DBA44, IgM more than IgD. Ki67 show like a very characteristic pattern. It's called targetoid pattern, where the outer layer is showing a higher like in positivity inside. Typically, they are CD10 negative, CD23 negative, CD43 negative, CD123 negative, annexin A1 negative, cyclin D1 negative, BCL6 negative, and SOX11 negative. There are some cases that show co-expression of some markers that can be seen in other subtypes, like CD5 in 20% of cases, CD11C in 50% of cases, CD25 in 30% of cases, and small percentage of CD103. Genetic features, 40% of cases show a common finding, which is the deletion 7q, but it's not very characteristic for splenic marginal zone lymphoma, as we can see it in other subtypes. There is ongoing evidence and future of the mutational analysis. As we can see here, CLIF2 and Notch pathway genes, specifically Notch1 and Notch2, are showing increased evidence. They are very commonly associated with splenic marginal zone lymphoma, as well as other genes that are related to the NF-kappa B pathway. Splenic marginal zone lymphoma is often indolent disease with good prognosis, and the overall survival is at least 10 years, and they usually respond to rituximab or splenectomy. Next, I'm going to talk briefly about the other entity, the splenic diffuse red bulb small B-cell lymphoma. Actually, it is a very rare entity. It is less than 1% of non-Hodgkin lymphomas. And it is accounted for 10% of splenectomy B-cell lymphomas. From the name, it is diffusely involved the splenic red bulb, but otherwise, it is very similar to the splenic marginal zone lymphoma in clinical, morphologic, immunophenotypic features. It shows pan B-cell markers, CD20 positive, CD79B positive, PAX5 positive, DBA44, and IgG. It is negative to the other specific markers for other lymphomas, and it is very characteristically negative for what is known the hairy cell markers, the CD11C, CD25, and CD103, and CD123, annexin A1. Similar to splenic marginal zone lymphoma, there is an increased evidence and information from the literature regarding cyclin D3 and cyclin D3 mutation. It is shown that in 70% of cases, there is an increase in positivity of cyclin D3 by immunohistochemistry, and also 26% of cases showing mutations in the cyclin D3 gene. But it is not very characteristic and seen in other subtypes. So this is the recommendation or the main point from the ICC classification. The differentiation between splenic marginal zone lymphoma and splenic diffuse red bulb small B-cell lymphoma needs a spleen histology. Even with the immunophenotype, even with the gene mutational analysis and the findings, it still requires a spleen histology. As mentioned, splenic marginal zone lymphoma is a white bulb disease. Splenic diffuse red bulb B-cell lymphoma is a red bulb disease. Next, I'm moving to the hairy cell leukemia. Hairy cell leukemia is a cytologic and immunophenotypic distinct indolent neoplasm of small mature B lymphoid cells with oval nuclei and abundant cytoplasm with so-called hairy cell or hairy projection involving the peripheral blood and diffusely infiltrate the bone marrow and the red bulb of the spleen. So it is very, as I mentioned, distinct in the matter of the presentation, clinical features, morphology, and immunophenotypic features. It is rare and accounts for 2% of lymphoid leukemias, and patient presented with a median age of 54, ranging from 23 to 85. Men is way affected more than women, and mostly patients present with fatigue, weakness, or weight loss, left upper quadrant pain because of the huge splenomegaly is seen in 90% of cases, hepatomegaly in 70%, pancytopenia in 75% of the cases, and a very characteristic finding is the monocytopenia, where monocytes are less than 500 per microliter. They tend to be seen in bone marrow and heavily infiltrate the spleen, and you can see occasionally and like few number of abnormal lymphoid cells in the peripheral blood, but usually in small numbers. Liver is affected or involved in 50 to 70% of the cases. Lymph nodes are rare. The morphologic features of hairy cell leukemia, I believe it's very known to most of you. It is commonly a small to medium-sized lymphoid cells with oval or indented, what is called kidney-shaped nucleus. It is less clumped compared to other types of B-cell lymphoma, and nuclei are absent. Cytoplasm is prominent and abundant and showing clearly the hairy projection, and the projections here are different. If you look carefully, they are very different from the splenic marginal zone lymphoma, or what is called the villus lymphocytes. The projections are seen all over all the sides and around the cell, instead of polar or one-sided villus projection in the splenic marginal zone lymphoma. So in the bone marrow, it range from interstitial, patchy to diffuse solid infiltration, and it is very characteristically widely spaced lymphoid cells with oval or indented nuclei with abundant cytoplasm, making very clear and prominent cell borders, making what is very known as the fried egg appearance, as you can notice here. Mitotic figures are absent, and it is very commonly show increased bone marrow fibrosis. In the spleen, hairy cell leukemia is involving the red bulb, and it making what is commonly known as red blood cell lakes, where you can see spots or areas of hemorrhage and RBCs surrounded clearly and nicely by the hairy cell leukemia cells, very clearly abundant cytoplasm cells surrounding these blood lakes. The immunophenotypic features of hairy cell leukemia, as the definition, it's very distinct, type of B-cell lymphoma. Although it is a B-cell neoplasm, but it is typically express CD11C, CD25, CD103, CD123, and annexin A1, and cyclin D1 is reported to be positive weekly, mostly weekly positive in hairy cell leukemia. It is known to be negative for CD5, CD10, CD23, CD43, and BCL6. Similarly, it is a very distinct subtype. It has a very characteristic BRAF V600E mutation, and it is believed that this is, the driving mutation and abnormality that showing the disease, and the main pathogenesis of the disease is because of that. There is increased number of cases specifically that are negative for BRAF V600E mutation. They show preference for the IGHV4-34 family of the immunoglobulin heavy chain, as well as MAP2 kinase 1 mutations. It is very, benign disease, I would say indolent. They respond very good to purine analogs and interferon alpha, and they achieve complete and durable remissions. On the other hand, the hairy cell leukemia variant, it is very rare. It accounts for less than 0.2% of lymphoid leukemias. It is actually resemble the classic hairy cell leukemia, but exhibit very distinct and variant features. So summarize them here. It shows leukocytosis at presentation, and the monocytopenia is absent. Also, by morphology, they typically show very prominent nucleoli. And in some literature, the old researcher, it was called a pro-lymphocytic hairy cell leukemia. It is typically and commonly negative for CD25. I cannot think about hairy cell leukemia with CD25 positive, and negative for CD123 and annexin A1. They lack the BRAF V600E mutation, and similarly to hairy cell leukemia, they show more usage for the IGHV4-34 gene family, and high frequency for TP53 and MAP2 kinase mutations. And they do not respond nicely and goodly to purine analogs. So this is a brief review about the splenic B cell lymphomas. So I was thinking just to, go with you about a suggested diagnostic algorithm for such cases. So I will think about the splenic B cell lymphomas when I have a splenomegaly, patient presented with a splenomegaly, and there is a lymphocytosis, whether absolute or relative. So first thing I will do, I will look at the morphology of the peripheral blood. So if I have a large cells, this makes life easy. I will think about the high-grade B cell lymphomas, DLBCL, Burkitt lymphoma, double hits, and the other things, like high-grade follicular, the polymorphic mantle. So I won't think about the splenic B cell lymphomas. If I have a small or moderate with abundant cytoplasm cells, I definitely will need flow cytometry. So if flow cytometry show a distinct and a very characteristic findings for other B cell lymphomas, like CD10 positive, I will think about follicular lymphoma. If CD5, CD23, CD43, CD200 are positive with DIM or negative CD20, this is clearly a classic CLL. If CD5 positive with cyclin D1, whether by flow or IHC, I will definitely think of a mantle cell lymphoma. If not, I will go think about the hairy cell leukemia. It has to have at least these three markers. The CD11C, very bright, CD25, and CD103. If not the three are present, we will go to the challenge of the what is commonly called as CD5 negative, CD10 negative, B lymphoproliferative disorder, or to lesser extent the CD5 positive B cell lymphoproliferative disorder with splenomegaly. So the differential diagnosis is the same entities that I described earlier, hairy cell leukemia variant, and the more common, the splenic marginal zone with, included into this category, the splenic diffuse red bulb small B cell lymphoma, and LPL, lymphoplasmacytic lymphoma.
2 minutes.
So this area was a very, interest to our group. So we were thinking about, checking a diagnostic utility using flow cytometry and targeted NGS. So we have checked and studied 2 cohorts, 34 cases for flow cytometry and 39 cases for targeted NGS in a group of low-grade B cell lymphoma. So I looked like, before I start, looking for other markers, I looked, to like get an idea about how overlapping we can see among these cases. So this is CD5. We can see here, splenic marginal zone lymphoma tend to show like good expression of CD5, as well as LPL. Maybe hairy cell leukemia variant is very low. This is CD11C, very characteristic strong positivity in the hairy cell leukemia group, whether the classic or the variant, but still we can see some positivity in the splenic marginal zone lymphoma. So this is CD25. You can see here the difference. See the end of the columns. So hairy cell leukemia is the strongest entity that shows CD25 expression, where hairy cell leukemia variant is, in the bottom showing dead negativity for CD25. But still, LPL, marginal zone, and splenic marginal zone lymphoma, some cases tend to show some positivity. So our group study, like this new marker, the CD1C, in the immunology literature, they mentioned some like subtypes of activated and immune responded B cells in the peripheral blood show some variability in CD1C. So we studied CD1C in this, cohort of low-grade B-cell lymphoma. Actually, it is very, useful for discriminating CLL from the others, but the other subgroups show like very and pretty similar, expression. The other marker is CD180. I think we have some, potential use here. As we can see, splenic marginal zone lymphoma is showing more expression compared to LPL, and it can help in the differentiating between the two subgroups. My colleagues, covered the next generation sequencing using like a group, like a good panel of genes that like cover Notch1, Notch pathway, NF-kappa-B, and some, tumor oncogenesis genes, and it is very, very helpful. You can see here, LPL tends to show very strong and like uniform, a mutation in the MYD88 gene, to a lesser extent the CXCR4. Whereas marginal zone lymphoma, including splenic marginal zone lymphoma, show like, like a good percentage of mutations in the NF-kappa-B pathway. Hairy cell leukemia is very characteristic, showing mutations in the BRAF, as well as the MAP2 kinase 1. So I believe, the targeted NGS is very, important tool in the low-grade B-cell lymphomas in general. So I will conclude with these two challenging cases. So we have, the first case is a 41 years old female presented with, leukocytosis, mainly absolute lymphocytosis, with a bone marrow involvement, and the lymphoma cells are very strongly positive for CD11C and negative for CD25. There is no lymphadenopathy. There is like very spleen, enlargement in the spleen. Genetics was normal, SPEP was normal. The initial diagnosis was, splenic marginal zone versus hairy cell leukemia variant, and the NGS was very helpful to, determine the hairy cell leukemia variant. The next case is 66 years old male, similar scenario, with splenomegaly. Bone marrow is involved by CD11C positive lymphoma cells, negative for CD25, and this one, there is a small, amount of IgM kappa, restricted protein. Genetics show deletion 17p. It is, seen in the splenic marginal zone lymphoma. So the NGS confirm the splenic marginal zone lymphoma by the presence of POT1 and TRAF mutation. And by this, I conclude my presentation, and I'll be happy to answer questions at the end.